Just to let you know that this session is supported by the LIGHT TB Consortium, coordinated at the Makerere University Lung Institute. The Lung Institute has been at the forefront of the global health security, but then we shouldn't forget that TB in its own right is also a global health security concern. You can't talk about TB and you don't talk about antimicrobial resistance. And one big statistic that should worry each one of us is that a third of the AMR-related deaths globally are attributed to MDR TB. 2/3 of the TB cases, or 2 out of the 3 cases of TB, go undiagnosed, and most of these are in men. So Mr. Fred Bill is the ED of the Fellowship of TB Survivors in Uganda. He's a board member of the Uganda Stop TB Partnership, and also is a member of the Advocacy Communication and Social Pillar at the National TB and Leprosy Program. You're welcome, Fred.
When they discovered that actually I'm having MDR, and when I was taken in the hospital, from 70 kgs, I came up to around 30 kgs at this time. It has not been easy. When I was told that I'm supposed to go through a treatment of 2 years, each and every day I will be taking 16 tablets, and every day I will be getting injection for 4 months. As a man, there was a number of challenges, because in my being at the hospital, you know, as a father, you are almost the breadwinner at home. In my hospital, even you find even my woman at home, she's even still coming, even asking me that at least you see today we don't have food. The children are crying, things are not okay. So with all that situation, I felt that with being here for 2 years, when even my children, they are supposed to be at school, my woman also somewhere when things get worse, she might even disappear. So after a duration of about 2-3 months, I started getting better. And then I requested the hospital. I said, no, since I'm the breadwinner at home, let me at least get back, because at the workplace, they were almost even actually replacing me, because they said we cannot keep you for all that duration in the hospital. But when I got back at my workplace, I started experiencing a lot of stigma. Then time came when I said, no, with all this kind of situation, I feel I can't continue with this. So I just made up my mind. I said, I cannot continue anymore with all this TB, otherwise my life will just go on like that. So time came when I just decided I left. Since that time, up to now, I said, no, with this, I cannot just sit to wait. I got back at home. I stayed like for about 6 months when I was doing nothing. Things were not easy. When you knock in other doors to look for other work, things were not easy. Then I said, no, I must be an advocate in this kind of situation.
So as a researcher, we looked at some of these factors. We went to several facilities, we engaged key stakeholders, and we tried to document this. And maybe just starting on some of the work that MLI has done, some of this came out resoundingly almost 10 years ago when we did our first prevalence survey. And the prevalence survey done in 2015 showed that TB is 4 times more prevalent among men compared to women. And when we also look at the notification, because we do notify cases, we are notifying more TB among men and women, but compared to the burden of TB that we know is among men, we find that many of the cases that are missed are among men. So Uganda has a male involvement strategy, but there were no gender-specific guidelines targeting TB screening, particularly among men. And when we go into a gender-sensitive approach, it doesn't mean that we're leaving out women or children or other age groups, but we need gender-sensitive approaches to address the male-specific needs and try to bring them onto care as we continue providing services to all the other groups.
I think that we need to understand exactly these circumstances of men, women, and children under which they live and work and study and grow more in depth, and that's the methods I use. So I use visual methods, some of which that Dr. Nidoi has talked about. I use photo voice. We do transects walks, so we go through the community, guided by community members to understand where do men, women, children live, where do they sleep, where do they study, where do they work. Because our health response will only be as good as we know our epidemic.
Came up with three main interventions that would address the higher burden of TB and the missed TB cases among men. We thought we'd introduce male-friendly services in these health facilities, and this included integrated screening for TB, HIV. We also added diabetes and screening for hypertension within the TB clinic. From the engagement that we've done with different stakeholders, we also saw that it was important to engage a male champion. We know that 2/3 of the healthcare workforce is female, and we felt that this engagement with a male TB champion, a male TB survivor, would be helpful and beneficial. I think we've all learned a lot from Fred's experience. We also improved screening for all using a summary stamp for all TB symptoms, and we gave out informational material in the community. So we assessed the feasibility, effectiveness, and cost effectiveness of this intervention, and recently we had a data validation workshop. As I've mentioned, participatory methods have really been key throughout the whole experience. So we went back to the facilities in which we implemented this study, disseminated the results, and also looked for explanation and meaning behind that.
There are not many people like Fred who get a chance to work within the formal health system as cough monitors, treatment supporters, village health teams, all those voluntary roles, these close to community providers that bridge the gap between affected communities and the formal health system. And I believe there are many more who do in their day-to-day life their little contributions to prevent and to respond to tuberculosis in their family and their community. And I think we can best document such experience through stories, and we use photo stories because a picture tells more than 1,000 words. So we give people cameras, we train them on ethics, on photography. We want to give them cameras to document how their day-to-day life looks like in their TB survivors, what they do to end TB in Uganda, and we hope to learn a lot from them and be able to come up with ideas how to support TB survivors in Uganda. We are very hopeful that this method will work because we have worked with it in other countries. In Malawi, we have worked with young people who have TB, and they have allowed us to very close in their intimate lives. Young men as caregivers, young men have shown us their mental health challenges, young men have shown us their vulnerabilities, young men have shown us that they were running businesses before they had TB and how that crushed, how TB has disrupted their education. So all these touching stories resonated very much with policymakers, and we hope that stories of TB survivors, not only their suffering, but also their contributions they do every day in their lives. That's what we hope to document in this study.
So thanks to the LIGHT Consortium and the Makerere University Lung Institute for bringing together this panel of experts to discuss this very pertinent issue.